Hello, everyone. I'm Dr. Carmen Puliafito. I'm here with Dr. Tony Stefater of the Ophthalmic Consultants of Boston. And Tony is going to join us on retinal synthesis today. Welcome.
Thank you. Thank you. Glad to be here.
Tony has done some really groundbreaking research on retinal tamponades. And that's today's subject, really, novel retinal tamponades. You've done such great work, but retinal tamponades have been a subject for the last 100 years. Isn't that correct?
Yes, it's as far as I know, the first gas injection was done more than 100 years ago, or air injection. So it's been an area of interest for a long time for the field.
So can you discuss the history of tamponades and how they've evolved to the present?
Yeah, I'm not an expert on the history of retina surgery, but obviously the pursuit of a treatment for retinal detachment has been something that people were struggling with and unable to easily achieve for decades. And it was only really in the sort of 70s and 80s that the surgery began to get more refined. I think Ulm was the first person to inject air into the eye as an attempt to treat retinal detachments in the early 1900s. And then I think, if my understanding is correct, Rosengren in the late 30s combined external drainage of subretinal fluid with air injection. And so that combined with this understanding that retinal holes were the cause of retinal detachments, and that if you reopposed the retina to the choroid and you diopthermized those breaks, you could treat retinal detachments. It was all pretty rudimentary, but there was definitely an understanding that something from the inside pushing the retina back out against the choroid was helpful in terms of keeping the retina attached while the diathermy, in that case, or laser now, results in an adhesion between the retina and the RPE. So, in terms of modern day surgery, SF6, C3F8, I mean, these were in common use in the 80s. And it was kind of amazing to us as me and Tommy, who we co-founded this pursuit when we were residents at developing a better tamponade. And it was amazing to us that the same tamponade, C3F8, SF6, the same approach, had been unchanged for 40 years, and it imposes a big burden on the patients. And so it didn't seem like it seemed like an exciting idea to try to pursue a better way to do this surgery that would eliminate that burden on the patients. And probably we found out later there was a reason why no one had done that in the last 30 or 40 years.
Well, and of course there's silicone oil.
There's also silicone oil, of course, and the approval history of that is interesting. That was approved during the AIDS epidemic, CMV retinitis, and it was approved, as a tamponade for those cases, detachments associated with those cases. And yes, silicone oil is effective, but there's big limitations there. The patient still have to position, of course. And there's definitely some literature about the final visual outcome on average being worse in patients that have silicone oil tamponade. And you can't see why the oil is in the eye very well, of course, and you still need a removal surgery at some point. So multiple ways to improve on that too.
So what's the ideal retinal tamponade?
The ideal retinal tamponade, or maybe we just call it sealant, is something that's applied to the retinal breaks. And that can be from filling the entire eye, or it could be from just applying something focally to the retinal breaks that prevents fluid from accessing the subretinal space while the chorioretinal adhesion forms after laser. And ideally, that tamponade does not rely on the position of the patient's head or eyes. And ideally, you can see clearly, so it doesn't cause a refractive shift that burdens the patients for weeks or months after surgery. And then ideally, you can fly, and ideally, you don't need any kind of removal surgery, that it just biodegrades and clears naturally from the eye without complication. A lot of people had thought about using hydrogels to achieve this kind of tamponade in the past, but efforts were limited by inflammation and cataract formation and high intraocular pressure upon clearance from these, natural degradation of the molecule and clearance from the eye. So an ideal tamponade solves the burdens placed on the patient. It eliminates the component of patient compliance in the outcomes of retinal surgery, and it doesn't cause any problems to the eye itself.
How did you get interested in seeking the ideal retinal tamponade?
Well, Tommy and I were residents and rotating through Dean Elliott's clinic at Mass Eye and Ear. It was obvious to us that the patients were all complaining about their back and their neck more than they were about their eye. And many people said it was the worst week of their entire life. And if you ask people who've been through this, they will say, yeah, that was the worst week of my entire life, actually. That's striking as a resident with kind of an outside view. I think people in the field, said, whoa, it works pretty well. The retinas are attached and, this, but from an outside view, you're like, well, we are also torturing the patients to get this reasonably good outcome. So can we still get the reasonably good outcome or maybe even a better outcome and eliminate this torture? And so that's kind of how it started. What became a thought exercise turned into collaborations with chemists and formation of a company and moving all the way through to clinical trials.
So how did you seek out chemical assistance?
Well, that's one of the benefits of being in a place where there's a lot of innovation. In Boston, there's a ton of there's a whole ecosystem around medical devices, innovation, and pharma. And basically, we just kind of asked around, and people suggested various polymer chemists that might be able to weigh in. And so we went to a couple different polymer chemists with basically a list of the criteria that we needed. Is there an ideal substance out there that could perform in this manner? And the major criteria we were looking for was, we wanted a hydrogel that you could put into the eye that would form a gel inside the eye, but could go through a small cannula. People had tried putting hydrogels in the eye to treat retinal detachments in animals, at least through, and it worked, but they had to make these big incisions in the eye to get the hydrogel into the eye without shearing the hydrogel to liquid. And so our basic concept was, if we developed a hydrogel that worked like an epoxy, it's liquid components, you mix them together and then they form the gel in situ, that might work. You could do the surgery, you have the retina attached under air, you could inject your hydrogel as a liquid and it would form the rigid gel inside the eyeball itself. And then other key criteria were we wanted the degradation products to be teeny tiny. Our goal was like, let's have the thing clear just through the retina, not even require the TM, make the breakdown molecules so small, with the goal of eliminating, high pressure upon hydrogel clearance. So it started with, the list of criteria, then, I get identifying a class of polymers and then a lot of modifications from there to make the polymer work well for the indication. And then also things that we as doctors don't necessarily think about, but like making sure the polymer could actually be manufactured in a reliable way and that there was a way to scale that manufacturing and there'd be a way to sterilize the product. Other things like that, which you realize after you're a few steps down the road are essential to something actually being a therapy.
So how many iterations of compounds have you gone through?
Well, I'd say most, the key backbone, key concept of the polymer is similar to what we had come to pretty early, but there's a lot of modifications around like what concentration, how do you solubilize these things? For instance, when we first started, you had to take the powder and you had to heat it up and shake it for like an hour to get it to go into solution. And it's only stable in the solution for, an hour. So that's not clinically viable. It's not going to work in the OR. Tell the doctor, okay, an hour before the surgery, boil this thing over on the back bench and shake it. And so there's been a series of iterations to get to a clinically reasonable or clinically useful product. But I would say, it's still an epoxy at the end of the day, and the intellectual property that everything's based on is essentially this epoxy concept.
So tell me about what the compound is today.
So it's a modified PEG and a modified PVA. So those two products, when mixed together, form a hydrogel that's hydrolyzable. And so it's a nice rigid gel that forms in situ, and then over time, the bonds naturally hydrolyze, and it goes back down to its original, close to its original products, modified PEG, modified PVA. And those are very, very small, less than 50 kilodaltons. So antibody size or smaller. And the product is supplied as two powders. You add PBS to the two powders, and then once you mix the two solutions, you have several minutes to use the product. Clinically, we've had a couple of iterations. There's iterations in the lab, and then there's iterations in the actual clinic. And obviously, to get to the clinic, you do a series of biocompatibility studies and a host of animal studies, and there's back and forth with regulatory bodies. But you still don't really know how something's going to work until you go to the human. The way we set up our first study was what we call an adaptive clinical study, where we basically, since we're doing something that's never been done before, and we're actually treating retinal detachments in a way that's not really been done before, we wanted to learn from each patient and modify not only the surgical protocol, but the preparation and other things around the hydrogel that might need to be changed, to make sure we were, developing an optimized product. So there's definitely been iteration in the clinic as well. So it takes thick skin. I've got a lot of respect for people that have actually brought a product to market that was novel, because it's definitely there's always going to be, significant bumps in the road.
Can you say a little bit about the clinical iterations that you went through?
Sure. Yeah. Well, originally we were conceiving of filling the entire eye with the hydrogel, just like you would do a silicone oil fill. And so the whole back of the eye would be filled with the gel, and it would seal the retina completely 360 degrees. That was nice because, you didn't have to be thoughtful about hydrogel insertion. You had to be thoughtful about your laser so that you identified all your breaks and laser, but you didn't have to be thoughtful about hydrogel insertion, just like you're not thoughtful about gas or oil insertion. You just, make sure it's not overfilled and the concentration's right. But even though these products were breaking down into tiny components, in the first 3 patients that we did this in, we did see high pressure upon hydrogel clearance. So at 4 weeks or so after surgery, the patients had high pressure. And that's not really viable. We can't have every patient having high pressure at 4 weeks. If we're going to try to replace what's a relatively safe surgery, which is, vitrectomy with gas.
Why did the pressure go high? That's
it probably has. Yeah, it's a very interesting question. It probably has to do with just burden of product. So, even if you inject antibodies into the eye, they're going to clear out without a problem. But if you inject like 1 billion antibodies into the eye, and they're all trying to clear through the trabecular meshwork at the same time, you're probably going to get a pressure surge. I should note that all of those 3 patients did fine at the end of the day. But, a pressure surge that's bringing the patient into the, emergency room is obviously a non-starter for, an actual, therapy we want to continue to advance. And so, we thought it was related to volume and related to just burden of clearance. And so we thought, how can we do the surgery with less? We tried, there was a lot of ideas, but basically what we settled on was developing a mechanism by which you could focally apply the hydrogel just to the retinal breaks. And so if you wait a few minutes until it's a viscous liquid, it kind of has the consistency of Helon at that point, or, Visco. And we developed a curved cannula, and we basically said, apply the small amounts of the hydrogel directly to the retinal breaks. And Then
Under
that was
air, under air.
under air, retina attached, under air, laser done, and then go in and with a curved cannula, kind of like a curved laser, and basically paint the hydrogel onto the breaks. That worked. You know, the patient that worked to treat patients where retinas were attached without any positioning. We were blown away. Patients had excellent vision just 4 or 5 days after a MAC off detachment repair because they had no tamponade in the way. We significantly, dramatically improved the pressure response that we saw from this, you know, with this change. And, you know, it was probably related to, you know, using 1% of the volume that we were using when we were doing the full fill. I'll just say in the rest of the patients for the pilot trial, there was some elevation in pressure. Usually it was around that 4-week time point, and it was always less than a day, and it was treatable with, you know, drops. But so there's further formulation changes we think we can make to address that last little issue. It's never perfect, but we're on the 1 yard line in terms of developing something that's pretty simple to use. Kind of changes the way you think about a tamponade and how you might repair retinas, and hopefully makes things a lot better for patients.
What about giant retinal tears?
Yeah, it should work for giant retinal tears. I think, you know, we don't know kind of what the brackets are around how much volume you can put in. You know, to give you some example, you know, one of the surgeons did a retinal detachment with 11 breaks and put in 25 microliters of hydrogel.
Wow.
So when you're actually putting it, just like painting it right on the breaks, you use shockingly little. So I think even with the GRT, you could, you know, if you just painted along your tear margin, you'd still be using way less than if you just indiscriminately filled the eye.
So how long does it take for the hydrogel to go away, and what does it look like when it's in the eye?
So it's optically clear. One of our, you know, one of our criteria was that if we were originally intending to fill the eye, so we wanted the refractive index to be the same as vitreous, 1.33, so that there would be no refractive shift, so patients could see after surgery. So it's still clear, even though that's not really required, you know, now that it's being applied to peripheral breaks. You know, I've been told by the investigators that, you know, they can see it. They think they can see it. Sometimes it's hard. It's kind of like looking for, you know, if you imagine trying to look for a puddle of viscoat in the back of the eye, it's like maybe that's there, but you can see it clearly on ultrasound, which is interesting. And so, you know, when you ultrasound these eyes, day after surgery, completely clear vitreous cavities filled with fluid, and you can see a little, you know, hyper-reflective bleb of hydrogel where you left it.
And when does it go away?
Clinically, it goes away like between 3 to 4 weeks on ultrasound, and that correlates with, you know, what we saw in terms of pressure increases around the 4-week time point. So it's interesting. In vitro, it lasted for less time. You know, we were kind of targeting 2 weeks. In the eye, it seems to stick around for a little longer, but cleared from the eye by this sort of 4-week time point.
What about macular holes?
Great question. It's interesting when you think about whether that would work for macular holes or not. I'd say I'm 50-50 on whether it would work. It could certainly work. It would definitely work to exclude fluid, right? So once you peel the ILM, you could put a dollop of hydrogel down over the hole and you would exclude fluid. But would you hold the retina open almost by putting this hydrogel there? We did some experiments looking at that, and it looks like the hydrogel would be too viscous to actually like dip down into the hole and like touch the RPE. So it might actually be fine. It might actually work like oil or gas and just sort of be a coating across the top of the retina, and it would still allow the you know, outer retina to migrate in. It's a great question. It might be a nice next study.
So where are you at? How many eyes have actually been in the clinical trial so far?
So the pilot study was small, it was seven eyes, you know, what we're envisioning now is, you know, moving towards the pivotal study, which will start towards the end of the year. And that study will be a much larger study that is a randomized controlled trial where we look for a couple of things. One is non-inferiority to gas. So the patients would get, either they'd be randomized to get either gas or a tamponade. And we would be looking at retinal attachment rates at 90 days to assess for non-inferiority. And we would also look for superiority of postoperative vision, which should happen, should be because, the vision will be poor in the gas patients. And then a secondary measure, of course, is like quality of life measurements for these patients. And in the patients that have had the surgery done, the PICA surgery, they've been very happy. They haven't positioned at all, and they've had good vision just a few days after surgery. It's actually interesting listening to them talk about their visual experience. In a patient with a MAC-off detachment, a couple of days after surgery, they're seeing, but it's like very distorted and warped. And then like 4 or 5 days after, their vision's pretty clear. Mm-hmm. So they're probably watching in real time as the subretinal, the last remaining bit of subretinal fluid is reabsorbed in the macula.
Well, congratulations on this work. It's really great to see how a patient complaint, which every retina surgeon has heard and has listened to and has not really had much to offer, prompted you to make, I think, a very significant advance in our understanding of retinal surgery. And I think it's good to call it a retinal. So you're going to call it a retinal sealant? Is that what?
I think that's a better way of thinking of it. Yeah.
Other than a tamponade, from tamponade to sealant, that will be the topic of your American Ophthalmologic Society thesis.
I'm not going to get ahead of myself, Carmen, but and I also just want to add that Tommy Strejewski, it was my co-resident, co-fellow, and he and I worked on this together from the very beginning. So we couldn't have done it. I don't think either one of us would say we could have done it without the other.
Yeah, I know Tommy. So thank you for coming on Retina Synthesis, and please promise to come back when the pivotal trial's over.
Absolutely, we'd love to.